Good afternoon, everyone. Welcome to today's National Neonatal POCUS Collaborative webinar. I'm Fatima Skandar-Afshari, and I'll be your moderator today. Before we start, just some general housekeeping items to make note of. The chat is disabled for the audience, but the moderators may send out general announcements via the chat. Please use the Q&A feature to post questions. We'll answer those during the Q&A panel session. This webinar is being recorded and will be uploaded to the collaborative website, neopocuscollab.com. Now to our main talk. Today is the first webinar in our Spring Cardiac POCUS three-part series, where we will be exploring cardiac POCUS in neonatology. Our guest speaker today is Dr. Patrick McNamara. Dr. McNamara is a staff neonatologist and the director of the Division of Neonatology at the University of Iowa State Family Children's Hospital and professor of pediatrics and internal medicine at the University of Iowa. He is currently chair of the Pan American Hemodynamic Collaborative, Pediatric Academic Society Neonatal Hemodynamics, Advisory and Neonatal Hemodynamics Special Interest Group at the American Society of Echocardiography. His clinical and research interests include myocardial performance in the setting of hemodynamically significant ductus arteriosus, pulmonary hypertension, and targeted neonatal echocardiography. He has published over 350 peer-reviewed publications, chapters, and other works. Dr. McNamara, please take it away.
Okay. You can give me the thumbs up, Fatima, whenever to confirm that the slides are good.
Your slide is perfect. Go ahead.
Perfect. Okay. Thank you so much, and congratulations to all of you for bringing the world of POCUS together, and certainly the ongoing friendship and collaboration we have as a hemodynamics community with the world of POCUS is incredibly important for us. What I actually thought I would focus on today really is the journey that we took in building the field of hemodynamics, which along its way has got some similarities kind of with how the field of POCUS and particularly cardiac POCUS is evolving, and kind of talk about some of the lessons that we've learned that may be of value, and then hopefully bring it back together. So for those of you that don't know me, kind of I am not clearly from the United States by my accent. I grew up in the west of Ireland, and my main passion in life was football, proper football that's round. And that's what I did. How I got through medical school, I'll never know, but I did. And I've had the real privilege of working in 4 healthcare systems: the Irish, the UK, the Canadian, and the American. And at different phases on my journey, I've really witnessed, the evolution of how imaging has become an integral part of who we are kind of as a neonatal community. I started off as a kind of a neonatal senior health officer at the Royal Maternity Hospital in Belfast. And to take you back in time, outside the United States, it's very uncommon to have a pediatric echo lab in your NICU or close to your NICU. Some places have it, most places do not. And at that point in time, as a trainee, every morning when I did call, I would have to get up and do a head scan on every baby kind of in the NICU that required it. And, getting competent imaging and starting to recognize that we need to look more, thoughtfully at the cardiovascular system than just kind of chasing blood pressure, I started to get interested in echocardiography. And in those days, the echo was not very good. And to make a diagnosis of a hemodynamically significant PDA was next to impossible because you couldn't see the duct. And at that point in time, and I tell this story to all our trainees, and when I would look at the main pulmonary artery on the right-hand side, you would see laminar flow. And if there was this very turbulent pattern, you would suspect this was a hemodynamically significant shunt. And I told that story so many times in 1995. This is what we did. Reagan Giesinger called this the 1995 sign. So if we go back and look at where we were in 1995, we really knew very, very little. And at that point in time, like most other places, the approach to cardiovascular care was based on the exclusive targeting of a mean blood pressure above the gestational age. And this was the standard that most people kind of subscribed to. And this came from the BPA report in 1992, which involved 20 pediatricians, of only whom 2 were neonatologists. And what they said was that we don't know what a normal blood pressure is, but it approximates the gestational age. Research is needed to define normative data. And it's kind of shocking that from that time point, we in the year 2024, and you go to not just NICUs, but PICUs, EDs, CVICUs, this is a standard that people are following and nobody has no idea why. This is where it came from. The world has changed very significantly since 1995. Computers are different, phones are different. You don't see people going around with Walkmans or CDs. Kind of long time since Brazil won the World Cup. And this is Blackburn, who are no longer in the Premier League. But when we think about all the evolution in life with respect to care, particularly of the sick newborn, many places are still doing the same thing that was happening in 1995. It all kind of kicked off kind of in the late 90s. And this is John Skinner, who published this very sentinel book called Echo for the Neonatologist, and wrote this very interesting article, Echo on the NICU, a job for the neonatologist and the cardiologist. And John was a pediatric cardiologist and recognized that you can't have different levels of care between centers that have on-site cardiology and centers that do not. And this really started off, getting people engaged in imaging. As all of you know, ultrasound is not something that's exclusively done by radiologists. Okay, once upon a time, as you can see from the picture on the left-hand side, it was really complicated, and you had, just like MRI today, you had to take the patient to an imaging system. But as time has gone on, bedside imaging has become very much a standard of care, not just in the NICU, but in the pediatric ICU, the adult intensives, and so forth. And you may not know, but echocardiography was actually performed by radiologists until the late 1970s. And at that point in time, the pediatric cardiologists of the era said, we need to be the ones that are doing these imaging because we're the ones that are looking after the patients day by day, which is very similar to the needs of the neonatologists. In the early evolution, particularly in adult care, there were a series of sentinel studies, and there even was a randomized controlled trial that showed that clinician-performed echocardiography for hypotension improved diagnostic accuracy. Some of you may have seen this before, but I'd share with you again. And, one of the sentinel events, certainly in my lifetime, I had started off learning echocardiography in Belfast. I moved to London, UK, and one of my first jobs there as a registrar, which is kind of like a fellow here, I was in a center that did not have on-site pediatric cardiology. I had some skill. I certainly did not have a year of hemodynamics, but I had some skill. And the neonatologist asked me, could I look at this child, 3-week-old, was in 23% oxygen, having frequent apneas. The chest X-ray showed, cardiomegaly. So we put the probe on the chest, and this is not this exact patient's echo. This is something similar to what we saw, because in those days we did not have iPhones. We didn't have the ability to send the images anywhere and record them like this. But there was this big black shadow around the heart. And I got on the phone to Mike Rigby, and Mike Rigby is a very eminent pediatric cardiologist at the Brompton Hospital in London. And I had been presenting cases to him remotely, things I would pick up on VSDs, pulmonary stenosis, and so forth. And he would come then see them in clinic, and I would do clinic with him. And I told him the story. I couldn't send him an iPhone. I said, it looks like a pericardial effusion. So I wasn't quite sure what to do. He said, why don't you just drain it? So being Irish, gung-ho, I stuck a needle in and drained off 25 mils of TPM. So why is this important? Well, in 1997, it was not on the radar of neonatologists, the association between PICC lines and sudden death. And it was only in a additional major statement by the British Pediatrics Association in 2001 that the first time was a sentinel document that, there were many babies who had died in the country, and this was a post-mortem diagnosis. And if we go back to this patient, 23% oxygen, having some spells, cardiomegaly. If I had not had the ability to do that scan on that day, that child would have had arrested. The likelihood that somebody would have thought needle pericardiocentesis was next to zero. So that for me truly was a life saved, and recognizing that we need to engage and do better. I talk about the troubled early 2000s because they were very troubled, and as Nick Evans and the group in Australia published their experience and that 40% of the NICUs were actually performing echocardiography, there were a series of other publications that talked about misdiagnosis. They talked about poor diagnostic accuracy between kind of non-cardiologists performing echocardiography. And the Ward and Purdy paper was the real one that hit the press, and certainly in Australia forced the group that were performing echocardiography as neonatologists to go separately, to actually disconnect from the cardiologists and build their own program called the CCPU. This paper cited that there were 46% of major errors in neonates. And what they failed to actually mention was who performed these evaluations. And they were not a single one was performed by a neonatologist. They were performed by adult cardiologists. Now, that's not to say that the neonatologist is not immune from misdiagnosis, but certainly it recognizes that when we perform imaging of a newborn who does not have a comprehensive cardiovascular evaluation, that there is an intrinsic potential risk of missing congenital heart disease. So let's go to 2001, and I decided to come to Toronto to do a 2-year neonatal echo fellowship during the day. I was in the echo lab, and this person on the bottom right is a guy by the name of Jeff Smallhorn. He was the echo lab director, incredible guy, and he took me under his wing. I did transport call at night, but I started to study, echocardiography. And actually, one of the things I did at the time was actually using 3D echo to actually look at the evaluation of the PD on the heart. And the 3D imaging was not that great. And, this did not turn out into be something very exciting. I presented something at PAS and so forth. But it's kind of scary that 20 plus years later, the 3D technology for neonates has not really improved very, very much, which really represents the gap between imaging developers and the population that we certainly care about. As a trainee, becoming a faculty, one of the big concerns that I had, and much of this still exists today, was that much of the diseases we care about and that we treat, one, our pediatric cardiologists were not interested in them in many centers. Not all, but many were not. And the data and the literature around treatment suggested that treatment makes no difference. So the two fundamental questions, this is relevant in terms of how we use imaging, how we build imaging programs, is have we really defined the population of interest correctly? And have we chosen the correct outcomes to adjudicate efficacy? So in putting it all together and thinking about why you should have some form of imaging program in the NICU, it comes down to really 3 or 4 things that are important. Number one, a symptom-based approach to care is imprecise, okay? All of these symptoms may have therapies that may help them, but collectively, all of these symptoms can mean different diagnoses. And we see this all the time. Babies that look on the outside, with a baby yesterday that looked like the child had classic pulmonary arterial hypertension with a pre-post ductal saturation difference. And most clinicians probably would have given that baby nitric oxide, but the baby had severe left ventricular dysfunction with a right to left ductal shunt supporting his systemic circulation. So precision in diagnosis is important, and we will never move the needle in enhancing care and developing research or outcomes-based research that's meaningful if we don't have diagnostic precision. The second is this silo thinking. Symptoms get put into boxes. The heart symptoms are in one box, the lung symptoms are in another box. And I like to talk about this with our trainees all the time. How oftentimes when you have a blood gas that shows respiratory acidosis, do you exclusively focus on lung recruitment and tidal volume? and mechanical ventilation strategies, but failed to recognize that pulmonary blood flow and RV function are essential determinants of CO2 clearance. Thirdly, and this is my most favorite slide that some of you may have seen before, but integral to the care, and particularly the cardiovascular hemodynamics care, is a recognition that it's not just about imaging, it's about physiology. And if you just look at that slide for a minute and ask yourself the question, can you match the law to the concept? Okay, the Windkessel effect is one example. People are shocked if I ask what is the Windkessel effect. It's not something that people talk about, but it's actually very important. And then finally, this concept, and this is a word I made up, which is called anatomology. Okay, much of the echoes performed in most neonatal centers are anatomic-derived studies in which information is interpreted in a subjective manner to provide to the neonatologist something. The PDA is open and the shunt is left to right. Okay, as a hemodynamics person, that doesn't help us at all. Okay, and so forth. The delay in recognition, the delay in the study performed by a technician who knows nothing about the baby, the study being interpreted by a cardiologist who's never seen the baby and just is looking at pictures. That works for anatomy. It doesn't work for physiology. So in moving beyond the status quo, we need to recognize that cardiovascular physiology is complex and is highly dynamic. And perhaps the lack of treatment benefit relates to diagnostic and therapeutic imprecision. The field really evolved and started to kick off in 2004, the first hemodynamics club. I was there as a junior faculty. And for the first time, there was a discussion, not just about blood pressure, but about blood flow. And getting people to recognize that as neonatal intensivists in taking care of sick babies is incredibly complex. And in changing the paradigm from a blood pressure focused approach to a tissue oxygenation or cellular metabolism based approach, you now had to think of many things that modulate oxygen delivery. And in particular, the cardiovascular components are very difficult to interpret clinically at the bedside. So to provide better care, you need to be able to study these things, not just at one time point, but sequentially. Blood pressure is still very important. It's an important component of cardiovascular well-being, but it is not the central interest. Over the next 6 years, certainly in Toronto, we entered this era of political turmoil in which we started to build a program in Toronto. There was, global concern regarding pediatric cardiology involvement, increasing interest in hemodynamics research, increasing requests for training, particularly in Toronto, and then this significant resistance of pediatric echo lab leadership to support a collaborative solution. And when I started to build this in Toronto and approached, the person who was the echo lab lead left, and the person who became the interim was vehemently opposed to this. And as a result of that, I met with my division director and he said, build it in neonatology. Don't worry about the cardiologist. And that's kind of what we did. So I'm sharing this with you because this is actually what most people don't know this. This is what the program looked like in Toronto at the time. This is not 1 year of training, but it was hands-on supervised training for 12 weeks, doing certain things, ongoing scanning, et cetera, et cetera. It was very limited compared to what we do today. But it got us going and it put us on the map. And in 2007, it was a very central debate. Keith Barrington and I, the Irish and the English debating was wonderful, kind of on this topic. And, the conclusion of the slide, I just put this out for my presentation then, clinical assessment alone is insufficient. Point of care, functional cardiac ultrasound, we've had so many names for this over time, is a valuable adjunct to routine clinical care and is an essential skill for neonatal intensivists. Things changed again in 2009. The pediatric cardiologist on a shining white horse, Luke Mertens, arrived in Toronto. And one of the first things he did was he asked to meet with me. And I remember that meeting. He sat down on my couch and he said, hey, why are you doing this all on your own? Why are you building this echo stuff? We as cardiologists would love to help you. And I said, Luke, I tried 4 or 5 years ago and I was told this will never happen and cardiology will never support it. That was a very central conversation because as a result of that, Luke went to the American Society of Echocardiography and petitioned the first writing group for targeted neonatal echo. And actually, it was kind of interesting because they wanted to call this limited neonatal echo, and I really had a problem with that because limited sounded like we were kind of handicapped in some way, that we weren't doing a proper echo and so forth. But it happened, and it really laid the platform for us to build the field. The early days in Toronto were not, it was difficult. Initially we had the Sonosite. Eventually we got the E9. Our room was small. This was the Reagan influence. She brought a nice light there to make it look nice and pretty and so forth. But we started to actually develop the field and to develop standardization, based on the guidelines. And I remember Luke telling me very clearly, the most important part here is to develop the science, to develop the program to the point that no cardiologist can question it, that you legitimize it based on your data and so forth. So out of this grew the hemodynamics consultation, recognizing that this was not just about imaging, but that to actually build the field in a way that no cardiologist could question us, it needs to be based on physiology, comprehensive understanding of pharmacology, and so forth. Hence, down the road, we now have formal fellowships. They're 1 year. They're advanced. The time in the Echo Lab has diminished. It used to be 4 months. It became 2 to 3 months. And now in Iowa, it's just a 1-month rotation in which they go there to learn congenital heart disease physiology. Most of the work is done in the NICU, performed by neonatologist trainees. And our trainees do up to 500-600 echo consultations, which is, much more than most pediatric cardiology trainees do in a 3-year fellowship. These are some of the early pioneers of the field. And I think I put this slide up because most of them are very familiar to you. They have become world leaders in what they do. And the comprehensive training has developed these individuals to that extent that they're not just clinicians performing assessments, but they're performing highly advanced imaging that scientifically is meaningful. There are many other things that we did over time to help build the field, to make it available from an education perspective. You will be familiar with our website. On the right-hand side, FIF and I developed the TNECHO app, which were adjunctive tools to support training. We embraced simulation, kind of their 2016, the National T&E Simulation Day in Toronto, to try to create that platform to help people, establish their program. And Canada now has got to the point that the training, the 1-year training, is now accredited as a diploma program by the Royal College of Surgeons. And the science has evolved. This is the slide I like to show to see that compared to the pre-TNECHO era, the numbers of publications, and this is probably now more than 1,000, has increased significantly. We're a special interest group at ACE, which has provided the endorsement by pediatric cardiology, and the field is growing substantially. It's now global. Okay, there are more than 60 sites across the NHRC, now more than 100 faculty, many of whom have been credentialed by the American Society of Echocardiography. Many individuals are now leading funded research programs. Again, adds endorsement to what we do politically. This is just a summary across the range of different things that we have done, developing normative data, validating imaging techniques, doing pharmacological evaluations, characterizing diseases, performing clinical trials. Really have established this field that no one can question the work that's been done. Very briefly, I just want to share some of the sentinel things that have taught me some lessons over time. And one of the first one was the work around PDA closure and particularly PDA surgery. I was asked to develop a process to enhance standardization of the selection of babies undergoing PDA closure. That process of categorization ultimately led to the concept of triaging and the concept of PDA score. And with more rigorous evaluation, our numbers of PDA closures fell in Toronto. We had lots of problems with cancellations and so forth. So as mentioned, PDA scoring came from this concept that not every baby undergoing PDA surgery is the same. You need to figure out who needs it most urgently and so forth. But the other thing that was important, and this is This happened a long time ago, and I remember it very vividly. I started to get interested in these babies and why they got sick. And this was a sentinel case of an infant that came over, was quite sick, had a big shunt. But after surgery, I came in the morning and the baby was on 3 vasopressors and steroids. And to cut a long story short, the baby died on day 2. Why? Why did this happen? And could we have prevented this was the question. So the first part of that journey was describing the illness, which had a predictable onset, okay, characterized by oxygenation failure, systolic hypotension, and needing cardiovascular support, and this worsening in lung recruitment, classically between 8 to 12 hours. In describing it, we next wanted to understand who it happened to, and again, this was a disease that was more likely in younger babies. So we conducted a series of mechanistic studies looking at the looking at the LV systolic function, diastolic function, and to cut a long story short, this was a disease of afterload. So afterload is on the x-axis, contractility is on the y-axis. And what you can see is that the slope of the line before was much less steep than afterwards, meaning that as afterload went up, contractility of the LV failed. And in addition to this, that respiratory deterioration, okay, was related to the impairment in diastolic function and a post-capillary phenotype leading to pulmonary edema. So having described the physiology, knowing that it doesn't happen immediately, how do you prevent this? Okay, was the next question. Milrinone is a therapy that's used with increasing frequency in NICUs, and this is the graph showing compared to 2005, okay, how it has increased significantly, and that increases even further. And most of the work came from the work kind of that we did in Toronto around pulmonary hypertension, and particularly its vasodilator effects. So mechanistically, Milrinone, which is a drug that enhances LV function and decreases afterload, made a lot of sense. So we introduced this as a standard of care based on rigorous criterion performed on an echo in 1 hour and demonstrated, again, a small cohort, but demonstrated a reduction in this problem, okay, and in the components of the problem. And then subsequently, that data persisted in the Toronto cohort. We went on and we validated this. It's something we need to do. It's important not to just do one study to show benefit. This is a study we did with a FIF al-Kafash showing that the babies in gray who had the worst LV function, this is based on LV systolic strain, who had the lowest cardiac output, treated with Milrinone, had recovery of their LV function to the pre-intervention values. So we didn't end there. This is not a disease just of PDA surgery. We recently looked at this in a cohort of 4 sites, Iowa, Toronto, nationwide, and Memphis, and demonstrated that consistently across these sites, babies do get sick even after cath closure. But it's a slightly different illness. They're hypertensive with respiratory failure. But interestingly, again, the group in yellow, which is the Iowa cohort, which are the Milrinone treated group, had the lowest instance of hypertension and respiratory impairment. To put the icing on the cake, we've now got to the point that we're just about to embark on a multi-center NHLBI-funded double-masked placebo-controlled trial of Milrinone after PDA closure, and some of your sites may be involved in that. But I wanted to share this with you, the journey that we took from describing the problem clinically, understanding it physiologically, performing a pharmacological appraisal, providing preliminary data, mechanistic data, validating the data, and now getting to the randomized controlled trial data is the way in which I believe we should be developing evidence for our preterm babies. The second example, briefly, and you may also be familiar with it, are the lessons that we've learned in the care of extremely preterm babies. I was a program that has a long-standing track record in providing exceptional care for extremely preterm babies, particularly at the limits of viability. Yet, there were babies that still had bad IVH, a very high rate of PDA surgery, and NEC was around 6%. We all know that as time has gone on, more babies are surviving, but the ability to modulate outcomes has been much less beneficial, particularly intraventricular hemorrhage and severe BPD. This is a very important piece of information because what it shows in 2 sites. The data on the left is Sweden, where they have a very non-aggressive approach to neonatal care. They avoid intubation, a non-aggressive approach to the PDA. This is survival, which increases as gestation increases and has increased over time. On the right-hand side, this is mortality in Japan, a very different approach. Mandatory ventilation, and some of these babies are ventilated up to 36 weeks. They're all put on dopamine and dobutamine. They have an aggressive approach to PDA, and pretty much everyone gets into medicine. Survival has improved across gestations over time. The most interesting part is that survival rate is exactly the same at 60% at 22 weeks gestation. So how do you reconcile with polar opposite approaches that care is the same? So one of the hallmarks of the field of hemodynamics is diagnostic precision. If diagnostic precision is high, the balance weighs towards therapeutic efficacy, and vice versa if diagnostic precision is low. So in sites like Japan, there are probably many babies who received unnecessary treatments, having treatment-related harm. So if you randomize babies to PDA therapy and you enroll a lot of babies that have PDAs that are going to close spontaneously or the shunts are low volume, you're probably going to have treatment-related harm, and trials won't demonstrate benefit. Vice versa, when you've got unrecognized disease, there may be disease-related harm. So common to both approaches is diagnostic and therapeutic in precision from a cardiovascular perspective. So the program here has got 6 faculty. This will further grow next year. We perform more than 2,000 consults per year. But the fundamental question we asked, is there a benefit to early screening? And within this, should you treat the PDA? There's some work from Jan Milton in Dublin, which shows that in orange, babies who had transitioned from low output to high output using non-invasive cardiac output monitoring were more likely to have adverse outcomes. Similarly, 2 studies, one from Shahab Nouri on the left-hand side, which showed if your cardiac output is low and it rose rapidly, you're more likely to get significant IVH, unlike the babies with stable cardiac output. Similar data from Martin Kluckow. So we hypothesized that the etiology of the IVH may have a cardiovascular explanation for it. So after birth, the LV is exposed to higher afterload as the placenta is eliminated, which may increase the likelihood of a low cardiac output state. As pulmonary vascular resistance falls due to better lung recruitment, lower CO2, higher PO2, PVR will fall, which will drive a left-right ductal shunt, which will drive an increase in preductal cardiac output, meaning the brain may transition from a low flow state to a high flow state. So this was our hypothesis. And it's an interesting hypothesis because when you look at the early trials of nitric oxide and high frequency ventilation, the risk of severe IVH was higher in both of these trials using therapies that reduce pulmonary vascular resistance. So I'm not going to go into details here. This is our screening approach, which based on the underlying diagnosis requires specific therapy. Okay, whether it's pulmonary hypertension or PDA, we provide a therapy specific to what is going on. This is the results from Reagan's screening epoch study, which demonstrated, despite the fact in the modern epoch that the rate of babies under 22, 23 weeks was significantly higher, and they were higher risk babies, there was a reduction in the composite outcome of death or severe IVH. And after adjustment for all these protective and adverse risk factors, that benefit remained. When you look at this on a probability graph, it shows it even more clearly. As time has gone on, the rate of death or severe IVH slightly increased, but you get to 2018 and you see this fairly significant reduction, which has continued to fall. The big surprise, if you go back to the last slide, was the reduction in NEC from 6% to 1%. So these data have persisted, and this is not a randomized controlled trial data, but this now represents the highest rate of survival of tiny babies anywhere in the world. We now have 9 survivors at 21 weeks gestation, including a 21+0 baby that went home at 4 weeks corrected gestation in low flow oxygen with no other major morbidities. This data on kind of the benefits of echo is not just immune to Iowa. Okay, this is some work from the Canadian centers, which showed that sites that did screening echo, okay, were more likely to have lower pre-discharge mortality, lower episode-related mortality, and lower rate of death or severe IVH. Some work from Spain across 5 centers, the sites that used early imaging with a more targeted approach to inotropes and PDA therapy also had a twofold lower rate of severe IVH. So we have evidence potentially of benefit, but it's not been smooth sailing. The applicability of the guidelines in North America were not easy. Okay, training was not necessarily competency-based. Okay, a lack of appreciation of the training needs of neonatologists was very much prevalent in that first set of guidelines. The mandate that the first echo must always be a comprehensive structural study. Okay, and then confusion between the role of hemodynamics and POCUS represents challenges that we faced. The recent publication of the guidelines for targeted neonatal echocardiography hopefully provide, more kind of logical ways in which this can be done, not just in North America, but across the world. Okay, the writing group was different. Okay, unlike the previous group, which was mostly pediatric cardiologists, this was mostly led by neonatologists. We changed the paradigm from a very nebulous approach to training to actually indications based on symptoms, indications based on disease, with the recognition of the things that we do as neonatologists to try to redevelop the training in a way that's specific to our needs and not the needs of a pediatric cardiology program. Now, this is all great, but it's not without limitations. Even in Iowa, 24/7 coverage is difficult. We're close to operationalizing this completely, but it's not been easy. Responsiveness to time-sensitive deteriorations, the fact that training takes time. We are up to now 9 programs in the US. We need more training programs, but we're making progress, which really emphasizes that this can't just be hemodynamics, even in centers that have kind of comprehensive hemodynamic programs. POCUS is something we have to embrace, hence why, with the guidelines, we had indications around cardiac POCUS. I put this up. This is a recent, publication from the survey we did across the US in actually looking at where are we with cardiac POCUS. And this is not to throw stones or anything, but this mirrors the survey that we conducted by Emer Finan around 2010, kind of across Canadian centers, with respect to the challenges we faced. There was a lack of standardization, a lack of rigor around archiving, imaging, et cetera, we were able to solve these problems, and there's no reason why all of this can't be solved. I've already mentioned the POCUS guidelines for cardiac POCUS, representing those acute scenarios in which there's a sudden deterioration and the need for time-sensitive evaluation, screening for effusions, like the case I presented earlier, kind of guiding the better evaluation of that collapsing child. Do I give volume? Do I give an inotrope? And so forth. But there certainly is need for more supportive research and to develop into standardized guidelines around cardiac POCUS, which I believe is in progress. And I congratulate everybody in the POCUS Collaborative for their work on this. This is the framework that we put together. And I think it's helpful, if you haven't seen it before, to guide how to interpret who images the patient. And it really stipulates, 3 questions. Is there a concern for major congenital heart disease, which sends you down the pediatric cardiology pathway? Is this an urgent, critical situation in which you need to exclude effusions, decide emergently on the need for cardiovascular therapy, which points you down the cardiac POCUS path? And then, if the questions are more appraisal of hemodynamic significance of PDA, evaluation of acute versus chronic pulmonary hypertension, heart dysfunction, and so forth, this really is what would get performed under neonatal hemodynamics and so forth. So what are my thoughts on the next steps for the world of POCUS? Well, I think close collaboration with the world of hemodynamics and working together, I think, is incredibly important. But what helped us most was the validation of imaging techniques, the development of science, research, and demonstrating the clinical impact. I think these are absolutely vital. to wrap up, I just want to remind us all that we're in a very, very different era. So, I got asked to give a talk at the Clemson MUSC hub on the interface between AI and hemodynamics. And if you asked me 2 years ago what was my understanding of AI, it was the movie, That Damn Robot, and Daniel Rios, who was doing kind of AI type predictive analytics research. I learned a lot. And what I learned is this is incredibly important. And as we build our imaging techniques, it is important that we draw a linkage between imaging and AI with computer vision that has the ability to automate some of the stuff that we're doing, with generative intelligent AI to take all that data to come up with complex algorithms. I think this represents our future. And to me, this is what I see as the future of neonatology. At the core is the neonatologist and the baby, who will always be there. But there's lots of data that are coming from our patients. Okay, machine learning will never tell you what's wrong, but it will tell you what's wrong, or that something is wrong. And we struggle sometimes with when do we next should evaluate the patient, particularly in the early screening echoes. So I think that's really important to have this close collaboration with our machine learning colleagues. We're starting to demonstrate the benefit of physiologic-based machine learning, and this is some work from Danielle Rios and Amy Hobbs and others from our program here who've actually demonstrated that AI can potentially differentiate, patients with very pathologic shunts from patients without shunts, which may help centers that don't have, comprehensive kind of big hemodynamics programs to identify the patients that may benefit from therapy. So to wrap up, I hope I've, convinced you that ultrasound is integral to the care of our babies. But we need to be thoughtful and careful around what we're using it for and who we're using it for. It's really, really important that, there's science and validation behind everything that we do. And obviously, the field of hemodynamics and T&E has gone a long way in developing that, but there's still things that we don't know about. We don't have normative data for the 21, 22, 23-week population. We need to get that. The integration of new programs is really important. And I think I would say to all of you is that the field of pediatric cardiology is highly supportive of hemodynamics. They're also supportive of cardiac POCUS, but they don't necessarily always understand which is which. And that clarification is really important because we've had individuals in the country who've been trying to establish hemodynamics and are told, no, we don't believe in this because they think that someone is going to do a very quick evaluation. So I think collaboration is the way to go. And I will stop there and I'd be happy to take some questions.
Thank you so much, Dr. McNamara, for such a wonderful and engaging talk. We will now move on to our Q&A expert panel discussion. Please put any questions into the Q&A and I will relay them to the panelists. Joining us today, along with Dr. McNamara, is Drs. Maki Fraga, Dr. Bombal, and Dr. Riley. Dr. Fraga is a professor of pediatrics at the University of Pennsylvania. She is the chair of the National Neonatal POCUS Collaborative and the chair of the Pediatric and Neonatal Ultrasound Committee for the Society of Critical Care Medicine. Dr. Bombal is an associate professor of pediatrics at Emory University and the vice chair of the National Neonatal POCUS Collaborative. She is a member of the Pan American Hemodynamics Group and the Targeted Neonatal Echocardiography Special Interest Group within the American Society of Echocardiography. Dr. Riley serves as the Director of Congenital Cardiac Non-Invasive Imaging and Echocardiography at Maine Health in Portland, Maine. His academic interests include evaluating the ability of innovative uses of ultrasound to guide management of children with heart disease. Thank you, everyone, for joining. First question I have is for you all. For programs who are interested in implementing cardiac POCUS or starting a T&E program, what is the very first step?
Who do you want to answer that? I can start off, and I think that the end of it really is the starting point, is to define what you're trying to do. I think is the most important thing. What is the scope of what you're trying to achieve? And a lot of people slip by getting caught in the middle between both worlds. And I think that is absolutely, crucial. Both fields are developing. Okay, they need to develop symbiotically, but you know, what we don't want to happen is people trying to do something in isolation of other imaging people. And I've seen that over time. I'm going to tell you guys a story. It's a real story of a 12-year-old child who presented to the emergency room at Sick Kids in Toronto. And I can't remember what the symptoms were, but some respiratory symptoms, et cetera, et cetera. So when the ED docs performed a POCUS evaluation, and they identified kind of heart dysfunction. So they called pediatric cardiology and said, we have this 12-year-old child who has heart dysfunction, blah, blah, blah. And the fellow listened to them and said, sorry, who are you? And why are you doing an evaluation? And the person explained, I did my training, blah, blah, blah. And the cardiology fellow said, well, we wouldn't do an echo in this situation normally. So there's no reason for us to see this child. Hung up the phone. Okay. The child arrested in the ED and ended up in ECMO. So that's a really important point. That's not to scare anyone, but it really speaks to the importance of everybody knowing within hospitals and within systems who's doing what, and that there's respect. It was a really dumb thing for that trainee to do. They should have thought, okay, if there's something on the echo, I should probably double check. Okay, not assume from an ego perspective that that person doesn't know what they're talking about. Okay, but I suspect things like that may have happened elsewhere too as well. So, as I said, we obviously have gone first through the hemodynamics route, but we're building our POCUS program, to be alongside that. And I think that's really, really important. And hopefully we can actually develop research around POCUS that would be of benefit. So
Thank you so much, Dr. McNamara. Dr. Riley, question for you. How do you recommend starting a collaboration with cardiologists?
Very good question. So my own personal experience is it just start with a lot of meetings. Just sit down, have lunch, have coffee, get to know people. As Dr. McNamara was just saying, just know who people are that are interested in the field within your institution, within your region. I met a lot with ER folks, ICU folks, and neonatologists over the years, and just as I said, just developing a common language, and you realize you're talking about the same thing, except with that you're trying to take down some of the vernacular and some of the some of the egos, so everyone gets on the same page. I think it's just starting with meetings and just discussing what you want to do. I think shared educational projects are really interesting to way to start. I think and also shared research. I mean, I think that it developing that sort of bilateral um, relationship where there's mutual beneficial nature of the relationships, I think are really helpful to build those teams, and that may be in education or maybe in research. And again, it gets down a little bit to people's time, of course, because I think it's people want to help and they want to be a part of it, and they have to have the covenant of taking care of these children together. But everyone in their lives has competing interests to be realistic, and so it's trying to identify where you can find commonality to build these relationships. I think is some of the early steps. But just starting to have meetings and make sure you're on the same page, I think is an easy first step.
can I add something to that? That's really important. So one of the things that I've discovered, we've had many meetings with many sites and many centers and helping them establish programs. You know, Oftentimes the starting point is that the pediatric cardiologists know everything about what the field is and know everything about the patient population. And that sometimes can be a problem because I've seen many different types of people. So you've got the people at one extreme who are, this should never happen, only cardiologists should look at patients. But on the other side, there are people that believe in this and they actually believe that neonatologists should do this stuff, but they're terrified of a situation whereby other people are now doing imaging and even more advanced imaging than what they do. and they feel that they now have to be responsible for that. So sometimes out of fear, they may push back and say, we can't have this. And it's not because they don't agree with it, but they're just afraid they're being perceived as an expert in this, but they don't feel like an expert. And we've seen that, recently a program in the US that they want to have a hemodynamics program, and the cardiologists there we're really nervous about how do we provide backup for this person, because we've never done hemodynamics. We've never done this advanced stuff. So I fully agree with that. Those discussions are crucial, and very honest, transparent discussions, because there are ways around that. We had a similar problem with a person that's known very well to all of you, Yasser El Said, who wanted to be trained, and he did a lot of echo in Egypt, and he was in Winnipeg, and he wanted to do the program, and the cardiologists there would not allow it because they themselves had no experience with hemodynamics. They wanted him to come to Toronto for a period of time, so they felt he had lived in that world of hemodynamics to get supported. So there's many permutations and combinations, and good communication is best.
One other thing to add about the beginning and starting relationships is definitely bravery, and a lot of pioneers are brave. And I think I loved your analogy that McNamara in the 1970s, and that was the start of the American Society of Echo. And radiology was saying you can't image the heart. We're the imagers, and that's why the American Society of Echo started. And so no one owns the heart, no one owns ultrasound. But it's hard. It's really, the heart is hard, and the heart is hard,
Yes.
and ultrasound is really hard. And I think it's just a matter of starting to put yourself out there and to learn these things, again, with supportive collaborative environments, but at the same time trying to learn them and doing them. I think it does take a lot of bravery.
Yeah, and I think that that's the key point, right? Never do this in isolation, whether you do cardiac point of care ultrasound or you do hemodynamics, because the more you work together, and the less chances you have of making mistakes in anything you do in medicine, regardless of imaging, right? So I think that, and going back to you, Patrick, you were telling your story where you come from. So as you know, I also come from a different place where clinical practice is absolutely different, right? And implementation of clinical tools in your daily practice is very, very easy to do. So here I have to learn to collaborate and to really build a program with a lot of effort and a lot of cautious, and I learned to also work with pediatric cardiologists to get this off the ground together, and when we brought this field of point of care ultrasound that includes cardiac point of care ultrasound, our main goal was always try to make this make it closer to more people, right? It's not as complex as you described your hemodynamics program and all you showed, but still, it helps intensivists to learn easy things to pick up and make them a little bit closer to understand the physiology of the patient, and then call immediately, cardiology, but knowing a little bit what's happening with the patient. So this is what we are advocating for, and never to work in isolation. I know Shasi wanted to say something else.
I agree with all of that, and we have here at Emory a multidisciplinary POCUS group, which has been really, really helpful to talk through both credentialing and equipment and educational opportunities, and be able to utilize other groups. We have the ER that's associated with that. We have cardiology, radiology, PICU, and we all can talk together about using resources. We do run boot camps together for POCUS, actually. And so this has been really useful to have that, and especially when you're starting off a new program and you don't have a lot of educational experience, but as Patrick nicely pointed out, you want to have your indications. This is what I want to use it for. Then trying to get resources both for machines, for education, for opportunities for learning. It's really helpful to have that multidisciplinary group behind you to do that. They're always people doing POCUS within the hospital, ultrasound within the hospital.
Like our program is so integrated within the pediatric cardiology infrastructure from a clinical perspective, but it's interesting. It's almost like how the world has changed significantly. The Iowa Pediatric Cardiology program is an excellent program, but it's very clinical focused. So for their trainees, they don't have a lot of exposure to advanced imaging-based research. So stuff that we've learned over the years in collaboration with many great pediatric cardiologists, we're now able to give back and mentoring some of the pediatric cardiology fellows and getting them involved in research. And, I think there's great symbiosis, and we've all learned, like the first iteration of the guidelines were essential to develop the field in North America. That would not have happened without the guidelines. However, what we didn't anticipate was how they would be perceived outside of the United States. And that was a big problem because having mandatory 6 months in an echo lab with all these various things that were required became impossible for people in the UK or the European countries, South America. They don't all have echo labs in every hospital, so hence making the latest version of the guidelines much more adaptable to different countries and different situations, and not taking away from the importance of the extent of the training, but it doesn't necessarily have to happen in the exact same way in every single place. And I think that was certainly helpful. And we had, Shazi was part of those guidelines. We had great support from our pediatric cardiology colleagues, kind of at the American Society of Echo, and I can tell you it's just so interesting. I was at the ACE meeting last year, how that our world is now perceived by pediatric echo leaders is so different, because we're recognized as the experts in this domain of physiology-based evaluation of the patients with structurally normal hearts, and I think, there are elements of that I think are going to be very important for the evolution of cardiac POCUS as well. And I think you guys are already working on that, which is tremendous. So, so anyway, we're all on the same team. So
We have another question. For those interested in getting into this field with the limited formal training options, what is the best way to go about this? And who would provide oversight of training quality?
talking about hemodynamics or POCUS?
Cardiac focus.
For cardiac POCUS, well, that's for Maki and Shazia to talk about. I can talk about hemodynamics because that is, we're in desperate need for more of the sites that are trained to become training sites. Because
Sure.
we're carrying the nation on our back at the moment, and it's too much.
Right, and this is the main problem that we are facing, right? And through the national collaborative, this is what we are trying to help with, bringing resources to those people who are in institutions that really don't have any support. There is always some, right? You have to look for it, but that they are just starting, right? Like who is going to help them develop that? So we, as you all know, there are many courses that are offered throughout the country just for the very basics or an introduction of point of care ultrasound that includes cardiac point of care ultrasound as well. But then after that, the main problem is going back to the institution and developing that themselves if they don't have any infrastructural support. So through the collaborative, we are also offering office hours, and within that hour, monthly office hours, within that hour, we allow people to bring their questions, even if they have images that they want to share, as long as they are de-identified, and just to guide them a little bit more on how to proceed. Same thing, we also offer, but this really doesn't happen that often, of course, like remote help, but it has become very busy trying to help all these small programs. So we always say that go back to your own place and find someone who can help you, from cardiology, from radiology. There is always someone, right? And then expand from there.
We are trying to work on this too from a collaborative standpoint, as far as basic and advanced POCUS, and trying to give some guidance for this. We're still early within us for neonatology to be able to do this, and there's not a governing body right now for this for POCUS. So I'm sure Alan will comment on this, but having some local help after these courses is going to be really important for education of images. And we did that early on too. We utilized cardiology and radiology and our PICU colleagues to help us with looking at images until we could get the expert enough to be able to look at them ourselves. So
yeah, I think two pieces of practical advice. I know we're running low on time. One is push and scream and yell for a communal imaging system, sharing system within a hospital system so that people can look at images. As Patrick's example from the first patient of like no one looked at the images, probably because they couldn't go all the way down to the ER and look at the machine. But if they're on a shared device, it's on the electronic medical record system. People speak ultrasound now. It's a common language. It's a common medical language, and you can speak in ultrasound, and that's going to lead to a lot of collaboration. The other thing in practical advice is the pediatric cardiologists are hard to get down there and teach non-cardiologists how to do echo. That's just always going to be the case. Finding ways to do it, I think, would be helpful. Adult emergency medicine, again, we're all kind of chasing them. They have hired sonographers to help teach their fellows. And so that is something to look into. Is there a lot of pediatric sonographers out there who have musculoskeletal injuries that don't want to be in the grind anymore, that are looking for a part-time gig? And so that is something more and more emergency departments and other non-cardiology divisions are looking for educators. It's that, as Dr. Fargo was describing, it's that deliberate practice, bedside, like expert advice in the moment, like what's this image showing me? The other side of it is also that hands-on skill of how to rotate, how to move the probe. I think that is really hard. And again, there are great technicians that are out there that are honestly less expensive than trying to pay for an FTE of a pediatric cardiologist.
Sorry, last question. Actually, it's a two-part question. We have two questions about ELBW population. First, do you perform echo for all extremely premature neonates in the first 2 to 3 days of life to manage hemodynamics and prevent IVH? And also, do you think it is important to have small baby unit practice homogeneity, such as ventilator management, etc., before establishing PDA management guidelines in a unit?
Okay, so we screen all babies under 27 weeks between 12 to 18 hours, and sometimes before that. So we had a 23-weeker yesterday that had rapidly, the one that I told you about with LV dysfunction, that baby had 4 echoes in 12 hours and transitioned from LV support to ultimately needing his PDA therapy by the 4th scan as the physiology changed, and doesn't have an IVH. Yeah, so the key though to that is one, so all our first scans have, it's a full study that has between 80 and 100 images with all the sweeps. We don't allow our trainees to do those scans until they've done probably close to 200 scans. And the reason for that is we want to get the buy-in from the bedside nurse. So the faculty are typically doing those evaluations in around 10 minutes, 10 to 15 minutes. It's really fast, really efficient, quick. Get the information. Don't destabilize the babies. And we actually have used our machine learning predictive, we use our sick bay data to actually look at what is the impact of those evaluations in that time point on heart rate, SATs, systolic, diastolic blood pressure, to show that actually you can perform these evaluations and the babies don't die, okay? Because in a lot of places that are trying to replicate this, they're told you can't touch these babies, they're going to have an IVH, the world is going to fall in, okay? If you've got highly trained people that can do it very efficiently and quickly, you can do these things. The second part of the question, so our approach is based on, the IO approach is a team. Standardization of care is imperative. The care doesn't change from one person to the next just because you're coming on shifts, okay? It's based on a very standard approach to ventilation. We don't extubate tiny babies. We use high-frequency jet ventilation. We've got clear guidelines for feeding, et cetera, and the answer to the question is there's no order. It's not that the lung becomes for the heart or the heart becomes for the lung, because if that's the case, well, you'll never recognize post-capillary lung disease because you'll always think it's a lung problem, okay? So kind of we look at those things symbiotically and try to make those evaluations, based on, what we see from an echo perspective, what we see from a lung perspective. And it's not infrequent that we're making changes to our mechanical ventilation based on what we see on the echo by babies being overinflated, particular. Less in Iowa, that was a big problem in Toronto and other sets where we use the oscillator and the babies get very overinflated. And that does impact the hemodynamics significantly. So I think it's, kind of, we have in our group, we have a heart-lung collaborative which is looking at how do we put the lung and the heart together in terms of care. So
Thank you so much, Dr. McNamara. Unfortunately, we are out of time today. Wish we could all speak for much longer. Thank you to our speaker and panelists for this wonderful discussion, and thank you all for joining us. In the chat, you'll see the link to the NeoPOCUS Collab website where you can find this webinar along with all of our prior webinars. Please join us again next month on February 25th for our second webinar in the Cardiac POCUS webinar series, where Dr. Shazia Bombal will discuss cardiac POCUS indications and considerations. Thank you again for joining. Have a wonderful rest of your day.
thanks, guys. Thanks for the invite.
Thank you.